Thanks so much, Mr. Chairman, for inviting me to this Congress, and I'm pleased to start my presentation. Anesthesia for video-assisted thoracoscopic surgery, what you need to know as anesthesiologists. I received the free airway device samples from AMBO and AirTrack in 2014 and 2015 for use in 3 studies. I have no direct financial or other interest in AMBO or AirTrack UK in the context of this talk and my studies. We are talking about a strong ring, including 3 rings, nurse, surgeons, and anesthesiologists. We are, as thoracic anesthesiologists, we are offering a menu of the day for our colleagues from thoracic surgery. We have starters on the menu, on top of menu, soup of the day, main course, beverages, and desserts. I'll talk about, through this presentation, about risk identifications, preoperative medicine and optimization, analgesic techniques, try to address answer to do anesthetics make a difference, lung isolation techniques and one lung ventilation, optimum deflation and awake VATS, and finally when you have to send your patient to ward or ICU. Risk identification, in our book, and you found a lot of publications about risk identification aiming to predict if we can cope with one lung ventilation during surgery and their post-operative dyspnea to provide prognosis for post-operative mortality on pulmonary as well as systemic complications, and to ensure the patients will have reasonable quality of life after removing their lung loops or after doing thoracic surgery. Risk identifications, we are going to identify the associated comorbidities, including cardiovascular, pulmonary, neuropsychiatric, gastrointestinal, renal, and endocrinal disease, which might impact the recovery of patients. Prediction for the need of post-operative ventilation, counting on the nutritional state, functional status, respiratory distress preoperatively, cardiopulmonary dysfunction, and hemodynamic instability. We also can predict the need for post-operative high dependency unit or intensive care unit admission, who is also predicted the post-operative outcomes. We have one of the most important predictors is the percentage of predicted post-operative FEV1, forced expiratory volume, in the first second. If it is more than 80%, that means the patient at low risk for post-operative pulmonary complications. 40 to 80%, patients need further evaluation in conjunction with predicted post-operative value for DELCO. And for 30 to 40%, that's meaning the patient don't necessarily, this is value don't necessarily preclude surgery, but also to be evaluated in the light of predicted post-operative value for DELCO and cardiopulmonary exercise testing. Diffusion lung capacity DELCO, if it is higher than 80%, the patient at low risk for post-operative pulmonary complication. For less than 60%, and greater than 40%, need further evaluation with predicted post-operative FEV1 and eventually submitted to chest physiotherapy program. And if less than 40%, there is a low limit and high risk for experiencing postoperative pulmonary complication and need for mechanical ventilation. We have some scores to evaluate our patients. Eurolung score 1 and 2 can be used. And as you can see here, we have a different parameters, including height, weight, predicted the postoperative FEV1, age, and gender, and extent of surgery, including pneumonectomy, less than pneumonectomy, or thoracotomy with pneumonectomy, as you can see here. And we have also, this is predicted for mortality. We can also predict morbidity based on predicted postoperative FEV1, age, and gender, and without extent of surgery. Another score could be used not for open thoracotomy like your score, but used for thoracoscopic surgery is Soraco score. Soraco score, as you can see, it has different items, including gender, age, American Society of Anesthesiologists physical class, performance status classification, dyspnea score, priority of surgery, either urgent or elective, and the procedure class according to extent of surgery, either pneumonectomy or less, and the diagnosis group, either benign or malignant disease, and comorbidity score as well. The predicted value for these scores is less evident compared to those used for cardiac predicted perioperative outcome after cardiac surgery, like your score or others. General recommendations, we are, as you know, we are in the WHO announced the pandemic of SARS-CoV-2 in March 2020, and we have some recommendations coming from the European Association of Cardiothoracic Anesthesiologists published this year, earlier in this year, for COVID patients for thoracic surgery. We have to limit the number of staff present in the room. And if possible, you can use an isolated negative pressure room with greater than 12 times air exchanges per hour. If this is not feasible, you have to consider other solutions like using a higher level of personal protective equipment, PPE, or doing in a positive pressure room, but try to reduce the positivity of the pressure less than the other parts of the operating theaters, and keep the doors closed as much as possible. Adequate level of personal protective equipment, the proper sequence of donning and doffing, the dedicated trolley for thoracic anesthesia. Here we can see we have airborne level, including face shield, N95 mask and hood, as well as fluid resistant gown, long sleeves, and double layer of gloves with shoe cover. For high burn level of and working positive pressure rooms or during interventional pulmonology using bronchoscope, you have to using a suit in this case and hood as well. This are the levels, as you can see here, covers hood, fitted the filtering face mask with the power of 3 or 2, N95 goggles or face shield, long sleeve gowns, double layers of gloves and overshoes. The level of PPE should be worn by anesthesiologists until the end of surgery with hand hygiene and immediately changing the outer layer of gloves after every patient contact. Here is an example to covering everything inside the room, including anesthesia machine, monitors, screens, computers, and even the car with plastic disposable sheets. A dedicated trolley, as you can see, for thoracic anesthesia, and the 2 HEPA filters should be attached to both inspiratory and expiratory limbs of the breathing circuit. We are talking about the starters. We have a problem in suboptimum positioning of the patient, which, as you can see, this is the optimum position in lateral decubitus. And if you have abnormal positioning, this is the optimum position as well. For extreme breaking of the table, it might be associated with nerve injury or might be associated with severe post-operative pain and can induce chronic neuropathic pain as well. Regarding the soup of the day on the menu, we are offering preoperative medicine as working as a preoperative physicians for risk optimization. This is including psychological support to decrease the stress and inflammatory response and promote wound healing. Education and counseling for the patient, including improving general nutritional habits, the lifestyle recommendations. It could be started in the pre-operative period and could be extended for the post-operative period. Smoking cessation, ideally for 4 weeks, if we're time allowing. Nicotine substitution using varenicline on the bupropion treatment could be used. For nutrition, if a patient has like cancer patients has the weight loss more than 10% or body mass index less than 18.5 kilogram per square meter or low albumin level, multidisciplinary approach should be needed. Alcohol abstinence and it should be considered because those patients, when you are going to withhold alcohol, they might have less incidence of acute lung injury, acute respiratory distress syndrome, also to reduce the incidence for arrhythmia during the post-operative period and atrial fibrillation, which is common after lung resections, and improve immune control. Measures also to improving the coagulation and processing, and also to reduce the neuroendocrine response to surgery and anesthesia. Oral hygiene should be considered preoperatively with chloroxidine mouthwash, which increased efficacy with toothbrushing protocols. It might risk the incidence of postoperative pulmonary complication, particularly pneumonia. Optimization of chronic obstructive lung disease with using of bronchodilators, using chest physiotherapy, busher drainage, and the using of steroids as much as needed is important. Preoperative pulmonary rehabilitations, including different rehabilitations programs for increasing of the capacity of respiratory muscles, diaphragm, and leg muscles to minimize the risk for deep venous thrombosis and pulmonary embolism. Identification and treatment of anemia is crucial as well. For here for optimization of COPD, as I told you, and for post, we have also for the soup of the day, we are providing different analgesic techniques. You have to know in this area research using of thoracic epidural anesthesia associated with reduced ICU length of stay after esophageal cancer surgery by 5 days, which is saving a lot of money and improving patient outcomes. In this study, comparing thoracic epidural with paravertebral, thoracic epidural associated with more incidences of hypotension requiring inotropic support and more incidence of arrhythmia. So paravertebral could have the same analgesic, comparable analgesic effects for thoracic epidural, but less complications. Chronic postoperative pain after thoracic surgery, particularly for thoracoscopy, lasted for more than 2 months and usually could happen in 45% of patients. It usually has a neuropathic component, and you have to know prevention is better than therapy. We have to learn our surgeons to respect tissues, to respect nerves, layers of muscles and tissues. Proper control of acute postoperative pain is important, so you have to consider using of regional techniques and multimodal approaches with considering opioid sparing. For prevention and for postoperative pain, some problems associated with more chronic postoperative pain is suboptimum intraoperative position, as I showed you earlier here. Extent of incisions the multi-layer intercostal incisions, pleural irritation, and thoracostomy tube insertion and positioning. Here is an example. So the thoracoscopic is just two parts or three parts or single part like this one. You can see just the closure of chest tube with entangling tissues like this one. It could be associated with severe postoperative pain and induce higher incidence of chronic postoperative pain after thoracoscopy. Also, single part, it is not exactly single part. You can see here how large is the incision with introducing of an instrument steroid. So could be associated with more neuropathic pain because of entangling or compression or dissection of intercostal nerves. In adherent rib fractures or intentional rib resection could be associated with higher incidence of chronic post-operative pain. So there are different players on the playground, as you can see. In this study, including two groups of patients, according to the type of muscle closure, is there intercostal muscle flap or standard suture associated with an intercostal, or both of them with intercostal block. You can see here the incidence of chronic pain is less with the layer closure with the intercostal muscle flap closure here, up to 6 months after surgery. However, the weakness of this study, it was an unblind study. Another study for subcostal closure technique for prevention post-thoracotomy pain syndrome. And you can see subcostal closure versus thoracoscopy and associated with comparable less pain scores, higher pain scores with thoracoscopy compared with subcostal closure, and more opioid consumption, as you can see, up to 2 months after surgery. The main course on the menu is the anesthetics. Anesthetics, there is a debate whether the volatile anesthetics or total intravenous anesthetics like propofol could be associated with less postoperative complications. In this study, the using of sevoflurane associated with 50% less incidence of PVCs after thoracic surgery. The incidence of major complications as well during hospitalization was in this study were comparable between desflurane and propofol. The study including 460 patients from 5 centers from Switzerland. And the overall survival, and you can see here, and propensity matched for 196 patients with non-small cell lung cancer were comparable with using TIVA or inhalational drugs. So there is no, there is still a debate about this, either to use TIVA or volatile anesthetics. Lung isolation, we are talking about a surgery in a contained space like a cave here on the right image, whereas the thoracotomy, open thoracotomy surgeon are working through a large room. So you need to facilitate surgical approach by lung separation or isolation and maximize lung deflation. And what are the indications to separate the lung for surgical exposure, for protecting of the healthy lung from blood like hemoptysis, pus in case of abscess, and the air like bronchopleural fistula or alveolar pulmonary proteinosis. Also, sometimes you need to provide lung isolation to do what's called differential lung ventilation in case of bronchopleural fistula. This is a very challenging business because we have some sort of difficulty with some type of patient, like a patient with previous tracheostomy. You have to check if it is a recent or old stoma, and you have to assess the stoma and circumferential diameter of the stoma to decide if you are going to insert a blocker or a specifically designed WM tube for tracheostomy, Shell's tube. Some patient might have amputated bronchus secondary to obstruction by large mucus plug, as you can see here for the left main bronchus. Some patient might have previous tracheobronchial stent, which is challenging to anesthetist to isolate the lungs. Deviated tracheal here in with a retrosternal goiter, as you can see, with a narrowing of trachea is a challenging because you cannot use a WN tube in this case except with extreme difficulties. Instead, you might think using single unit tube with a blocker. Steep angulation of right mean stem bronchus as well is acknowledged. And here a deviation of the trachea like cardiac herniation after pneumonectomy, 2 days after pneumonectomy is another complications which considered during lung isolation. Patient with scoliosis with different lung volumes and deviated tracheobronchial tree should be individualized these patients when you are going to plan for lung isolation. Same for tracheostomized patients. Patients with large aortic aneurysm with occluding of one of the main bronchus, here is the left main bronchus is occluded. So if you are going to isolate the lung for surgical approach on the left lung, you have to consider right side tube. Similarly, if you have endobronchial mass obstructing the right main bronchus here, you have to consider isolating using of left side W tube. Additionally, if you are going to, particularly if you are going to use the right side W tube, or you are going to place a blocker in the right main stem bronchus, you have to measure the distance of takeoff of the right upper lobe from the carotid deviation. You can see here we have early takeoff, which is leading to herniation of the cuff. Either you cannot ventilate the right upper lobe here, or you would spare the deflation of the right upper lobe, and that is what hampers the surgeon during surgical approach. Patients with disrupted main stem bronchus, it is a challengeable because you have only solution to use a WN tube to the other side. Here we are luckily that we have a disrupted right main bronchus, so we can use left side tube here. Some patients might have post-intubation stenosis, and it is difficult to advance the tube inside the tracheobronchial tree. How can we do that job? Probably, and we are working, and when you are using the blockers, we are working like tunnels, which is used by terrorists in Sinai, Pennsylvania. And we are going to kick the ball to close the tunnel opening. In the same, here we are using either WN tubes with 2 lumens, as you can see, or in this survey, national surveys, you can see most of practitioners in Middle East and UK and Italy are using WN tube as a first choice, to some extent in Germany as well. Left side tube, we are placing the tip of endobronchial lumen into the left main stem bronchus. We have 2 cuffs, proximal cuff to isolate the trachea and distal cuff to isolate the target bronchus. We have 2 lumens, one shorter lumen to ventilate the right lung here and one longer lumen to ventilate the left lung here. Right side tube. The tube is placed on right side. You have to take care to not occluding the entrance of the right upper lobe, as I explained earlier. We have a different, and the price is variable according to the country between the left and right WN tubes, and right WN tube associated has unique Bennett-shaped cuff and the slot here the ventilating of right upper lobe. The left WN tube is longer and steep, the cuff is spherical, and there is no slot here. Right side tube has a limited indications nowadays for left pneumonectomy, left sleeve resection, and left bronchial obstruction. We are using usually polyvinyl chloride tubes. However, there is one more efficient but more expensive tube, which is still broncho with reinforced distal tip and silicone-based tube. Additionally, nowadays they provide VivaSight with embedded camera at the tip of the tracheal lumen, so you don't need to look with a fiber optic. However, fortunately, You cannot, that using of Vivacide cannot preclude the using of fibroscope to confirm the proper tip position after placing of W tube. Using of different type of blockers, either outer to the tube, outer the lumen of the tube, you can see the blocker is outside the tube, or through the tube itself. It could be helpful to isolate lungs. As I told you, there is a specifically designed tube for trachestomized patients called short tube, W tube. It's called Shelly tube. A contraindication to use of W tube is a relation, including the passage of W tube if you have a risk for aspiration or difficult airway. However, difficult airway is not absolute contraindication in the light of growing up the era of video laryngoscopes and extremely ill patients with severely hypoxemic, counting on high level of PEEP, high level of I2, particularly for COVID patients undergoing emergency thoracic surgery, and single lumen tube in place, you need to just put a blocker and not exchange to W tube. This is the indication of blocker. Here is one of the blocker, which is easy blocker. And we have a different areas of blockers. The time to place a blocker. This is the contraindication for W tube, for difficult airway, risk for aspiration, extremely ill patients with single lumen tube in situ, for isolating bronchopleural fistula, or selective lobar blockade in some patients with low pulmonary reserve or previous pulmonary resection. You don't, for example, if you have a patient who is previous left pneumectomy and there is a surgery on the right side, it doesn't make sense to deflate the whole right side. Here you are using a blocker to just deflate the operating loop, either the upper, middle, or lower loop on the right side. It's called selective lobar blockade. You are selectively block one of the apples, which is the red one here. As you can see here, the blocker is advanced to block the bronchus intermedius, or for example, to block the right upper loop here. Pediatric lung isolation and younger than 8 years, there is no place for W tube, and even for 11 years old, so usually we are using blockers. Surgical exposure, one of the problem, if you don't have adequate deflation with using W tube sometimes, and you might use the bronchial blockers in addition to W tube for lung protection from blood and pus. When not to use the blockers, if you have a blocked route. If you are going to block the right side and you have endobronchial mass on the right side, or if you have extramural extraluminal obstruction of the right main bronchus, you cannot use the blockers. As I showed you earlier, we have a different types of blocker. This one is called armed blocker. It has a nylon loop at the tip entangling the fiber optic, and both of them inserted as a one set. We have a Fuji blocker with a torque control tip, and we have different types of cuffs. There is a Coptic bronchial blocker with angulated tip, also from Fuji previously and now from Ambu. Easy blocker, as I told you, there is the two branches. It is encroaching over the carina, and if you want to inflate the right side and working on right side, you can inflate the cuff under vision or left side. It could be used for sequential surgery, and also can be used for unilateral surgery. Main course also one lung ventilation. When you are going to have a patient with right thoracoscopy, you are going to deflate the right lung. In postoperative period, after 1 or 2 days, if you found the left lung is wide, it is your fault. If you found the right lung is white, this is your fault because this is the ventilated lung. And the operative lung, in the left lung, if it is white, that's meaning secondary to surgical injury. So we have a ventilated lung, which could be induced with, you can see how much inflammatory cells are infiltrating the alveoli in the ventilated lung, whereas the collapsed lungs, there is a few inflammatory cells. So we are injuring or hurting the patient healthy lung or non-surgical lung. This is secondary to atelectic trauma. You are not using a good ventilation leading to atelectasis, as you can see, or secondary to ventilation at a high volume and causing parotrauma and overdistension with release of inflammatory cytokines and inflammatory cells. While lung ventilation is usually associated with increased incidence of hypoxemia, it is dramatically decreased over the last 2 decades. It was earlier 5 to 10%. Now you can see it only in 2 to 5% of patients. We have a settings for the ventilated dependent lung, which is the non-surgical lung. FI2, you have to titrate the fraction of inspired oxygen between 30 to 100%, and you have to consider the minimum percent required to maintain saturation. You don't need to maintain saturation at 97, 98, no. The target is 90 to 92 in adult healthy patient, and in geriatric, you can accept up to 88% to 90% preferred oxygen saturation. Tidal volume, we are titrating tidal volume not on the whole body weight, but in predicted body weight using specific tables. You can download them from ERDS network, and usually we are titrating tidal volume for the dependent ventilated non-surgical lung to 4 to 6 milliliter per kilogram of predicted body weight. Beep, it could be used in all patients except the patients of COPD or hyperinflation. For the best beep, you can use just 5 beep or 7 beep or 10 beep. However, it is best to individualize beep using a beep decrement trial. You will start with the pressure control mode with a target tidal volume 4 to 6, respiratory 15, IR ratio 1 to 2. And then for the first 2 minutes, you have to use a beep of 20 and look for lung compliance in your monitor. If you found lung, and then decrease the beep level to 18 for further 2 minutes and look for compliance. And same 16 for 2 minutes, 14, 12, 10, 8, 6, and 4. Every one of them for 2 minutes. You have to look for the highest level of compliance, and then you have to go to the level 2. For example, if you found the highest compliance with beep of 12, and then you have to adjust your beep level to 10. Mode of ventilation, pressure control or volume control, or pressure control volume guarantee. Using of pressure controls in general or with the volume guarantee, it could be associated with lower peak and plateau pressure and hence less incidence of parotrauma. IR ratio could be used as 1 to 2 or 1 to 3 if you need to hyperventilate the lung to reduce the incidence of hypercarbia. However, if you are concerned about hypoxemia, you can consider using inverse IR ratio 1 to 1 or 1 to 1.5 to 1. Alveolar recruitment strategy. We have 2 types of recruitment. Static recruitment, you have to shift for pressure control mode if you are not using it. Frequency of 15, IR ratio 1 to 2, and 0 beep, and keep the peak pressure 40 for 10 to 40 seconds. It's called static recruitment. It can be used for 1 lung ventilation as well as for 2 lung ventilation for general anesthesia. Staircase or cyclic recruitment, same setting, pressure control mode, frequency of 15, IR ratio 1 to 2, and we have 4 steps. First, you will start with a pressure control level of 25 over beep of 5 for 10 breaths. Then you have to increase 5 for each of them, so it will be 30 over 10 for another 10 breaths, increase by 5, 35 over 15 for 10 breaths, increase by 5, 40 to 20 for 10 breaths. It's called staircase or cyclic recruitment maneuvers. Permissive hypercarbia was allowing BCO2 to rising, but less than 70, and BH more than 7.25 can be considered. What's about the surgical deflated non-dependent lung? You can supply oxygen insufflations directly. You can do intermittent reinflation if you have hypoxemic patients, particularly for life-threatening conditions. And you can applying CPAP, low levels of CPAP 1 to 2 centimeter, or using high frequency post-pressure ventilation, just shift your ventilator to pediatric mode and use tidal volume 2 to 3 ml per kg. You can read here 200. Keep the frequency of 60, 0 beep, and I ratio 1 to 3.5 to 1 4.5. It's called high frequency post-pressure ventilation here. Another, if you have a machines, you can use non-dependent lung high frequency jet ventilation or non-dependent lung high frequency percussive ventilation. This is CPAP circuit. It is attached to the non-ventilated lung, and you can adjust the level of CPAP here. We are still talking about main course. For fluid therapy, we have liberal, restrictive, or goal-directed therapy, which is best. You can see the patients in these different studies, patients undergoing pneumonectomy or pulmonary resection or osteophagy, patients received more fluids of higher incidence of acute lung injury than those received less amount of fluids. So the fluids are harmful to the patient. And at the same time, severe restriction could be associated with acute kidney injury. So don't flood the patient lung with fluids, like fill a temple here, and don't keep it dry. So it's better to have a goal-directed therapy. In general, you have to maintain a balance within the first 24 hours of surgery, less than 20 milliliter per kilogram. You shouldn't use more than 2 liters during the first 24 hours of crystalloids, and 3 liters during the first 24 hours, 2 liters intraoperatively. Colloids only reserve it if you have to replace equivalent volume of blood loss. However, you still have hemoglobin greater than 8. You don't need to transfuse. Here you have to use colloids. You don't need to maintain urine output of 1 or greater than 1. Only greater than half milliliter per kilogram per hour is necessary with using of vasopressors or inotropes rather than infusing fluids. Don't drown the dependent ventilated non-surgical lung. Using of different monitors like PICO or Vigilio for monitoring of fluid responsiveness or goal-directed therapy could be helpful. Because the fluids, here is a glycolex, which is a lining for the vascular lumen, and you could be damaged by fluids and damaged, as you can see here, with a decrease in thickness. Optimum deflation, one of the major issues which is leading to flowing of surgical approach is inadequate lung deflation, which is an underestimated or overestimated problem. We'll see. You shouldn't keep the lung hepatized or maximum deflated like the balloon here, and you shouldn't keep it inflated to hamper the surgical approach. And here you should consider using of suction on the bronchial blockers or double lumen tube. Continuous suctioning could be helpful, but you have to consider using low levels of suction because higher levels than 30 centimeter water of negative suction might leading to extradation of fluids inside the alveoli and developing of unilateral pulmonary edema. Awake VATS is not a mice. We are talking about enhanced recovery after surgery, and this can be done for, we have awake cardiac surgery, which is not a mice. Awake thoracic surgery is not a mice as well. There is no deleterious, this is one of our patients awake during thoracic surgery, spontaneously breathing on face mask. There is no deleterious effects of general anesthesia and one lung ventilation. There is superior postoperative analgesia, reduced thrombotic complications, decreased surgical stress response, shorter operating room time and hospital stay, lower cost, better satisfaction, and comparable mortality rate. You have to focus on selecting the most feasible candidate for awake thoracic surgery. It should be ASAP. When you are starting the program of awake thoracic surgery, you have to consider first Patient with ASA physical class 1 to 4 and lower classes is better at your beginning. Body mass index should be less than 30 if you need to convert the position from lateral to supine position, and to reduce the risk of hypoventilation, the incidence of hypoventilation. Stable cardiovascular and respiratory parameters. There is no phrenic nerve paralysis on the non-operating side. No contraindication for regional anesthetic techniques, and there is no unpredicted surgical difficulties like extensive adhesions or central mass greater than 6 centimeters in diameter. Reasons for converting to general anesthesia, including persistent hypoxemia, tachypnea, poor pain control, or patient become panic. Surgical reason, unsatisfactory lung collapse, extensive pleural adhesions, uncontrolled bleeding like injury of one of the pulmonary vessels, significant mediastinal movement. We are also offering beverages for our surgeons. So we are giving them an answer when you should send the patient after surgery to ward or ICU. Shortage of ICU bed and the fully booked ICU beds, as you know, leading to a lot of cancellations of surgery or unplanned admission to ICU and increase in workload. Postoperative complications which leading to ICU admission after pulmonary resection, mainly secondary to pulmonary complications, including pneumonia, atelectasis, acute lung injury, ARDS, air leak, bronchopleural fistula, pulmonary embolism, or prolonged need for mechanical ventilation longer than 72 hours. And less commonly, cardiac complications, either myocardial ischemia, or arrhythmia, or CVA. The admission of ICU is needed after thoracic surgery is needed for invasive or non-invasive ventilation, re-intubation, acute respiratory failure, hemodynamic instability or shock, postoperative pulmonary complication, BPCs, as a recommendation by anesthesiologist or surgeon. If you have a policy to maintain the patient on non-invasive ventilation ward, so you don't need to send the patient to ICU. In this study, in the patients undergoing major lung resection over 6 years at 3 centers, including 1,200 patients. And Bernoulli has defined, Alexander Bernoulli, variables scoring including age greater than 65, predicted postoperative, FEV1 less than 65, predicted postoperative DELCO less than 50, cardiac morbidities, and pneumonectomy is Bernoulli score. Why do thoracic patients go to ICU for, and here is a score for Benherio, the risk factors including pneumonectomy, ASA physical class 3 or greater, severe COPD, predicted postoperative FEV1 or predicted postoperative DELCO less than 40, cardiac conditions, SCVO2 baseline less than 90, and severe restrictive lung disease. This is the score of Benherio here. Where is the scoring system missing something? Less invasiveness of surgery under trauma patients. We also offering desserts at the end of the day for our surgeons. As anesthetist, we are offering during thoracoscopy fibroscopic checking for maintenance of patency of bronchus after resection and closure of the bronchus, the open bronchus, and to exclude air leakage by estimating the difference between inspired and expired tidal volume, adequacy of anastomosis under vision and by air leak and under vision by bronchoscope, and we are offering interventional bronchoscopy. So in conclusion, as anesthetists, we are offering a long menu for our colleagues in thoracic surgery, and they are getting the most of these benefits for the best of our patients. Thank you so much for your listening.